What is the most likely cause of this patient's condition? Right, that's the last line of the question. We have a 35-year-old man who attempted to climb Mount Everest at an altitude of 7,000 meters. He became short of breath and developed a dusky blue tinge around his face and lips. A physician in the climbing party performed a rudimentary physical examination, which reveals a respiratory rate of 30 per minute, BP 130 over 90, and heart rate over 108, and temperature is 36.4, with a few basal crackles on the right side of the chest. Now, there is no jugular venous distension or dependent edema was noted. With this information, the mountain climber was sent down the mountain for further evaluation. Chest X-ray is normal with a normal heart size. So what do you think is the cause of this condition? So all these hypoxias have something that will set the question apart, which I'm sure all of you know, but I'm just putting it out there. Right, hypoxemic hypoxia is a condition of insufficient oxygen. The word itself tells you, correct? In the arteries. Now, this can be caused by low environmental content, which is seen in extremely higher altitudes or inappropriately maintained diving operations. Other causes are, which include disruption of the respiratory drive, shunting of blood, and ventilation perfusion mismatch, which is seen in pulmonary embolism. What are the symptoms of hypoxia? It depends on severity, but most commonly they're present with headaches, fatigue or tiredness, or shortness of breath, palpitations, higher blood pressure, lightheadedness, nausea and vomiting, cyanosis, confusion and disorientation, seizures, and loss of consciousness. Now, you might ask me this question, ma'am, should we remember all of this? It's not required. Okay, just know the ANS symptoms. And other than that, your headache, fatigue, shortness of breath, dizziness, I think this will come out of practice. You don't have to remember it specifically. Okay, we know oxygen is an integral part of cellular respiration, and it acts as a final electron acceptor in your ETC pathway, correct? Now, if this was a diffusion limited hypoxia, what would have happened? It is an alveolar capillary interface which is disrupted. Now, this is seen in pulmonary edema or fibrosis, right, of the lung parenchyma, which is not there in the question at all. So obviously it's ruled out. Perfect. PaO2 saturation and gas exchange are normal in cases of anemic hypoxia. The problem is a decrease in HB concentration, which decreases the O2 carrying capacity in the blood. This condition will present with exertional dyspnea and exercise intolerance. All right. Now, ischemic hypoxia or stagnant hypoxia is defined as a decrease in the arterial blood flow due to thrombi or decreased cardiac output. Either there's an obstruction or your production center is at stake, which is your heart. So ischemia due to a thrombus in the muscular arteries will produce tissue hypoxia. Cardiogenic shock and hypovolemia also decrease arterial blood flow, but they present in a different way. That's all. Now, methemoglobinemia presents with cyanosis on physical examination, which cannot be reversed back with 100% oxygen. That's what you have to remember. The hemoglobin molecule is bound to Fe3 plus instead of your Fe2. Fe3 has definitely a stronger affinity to oxygen, and it does not, but the thing is, it has so strong affinity, it won't give the oxygen away. That is why we have hypoxia. I hope this is clear. This is a very simple concept, very important to understand. Okay, so in the end, the learning objective is hypoxemic hypoxia is a condition of insufficient oxygen content in the arteries. This can be caused by low environmental oxygen content seen either in high altitudes or inappropriately maintained diving operations. Now, you might have observed or heard of people getting headache when they go on treks on a mountain. It's because of hypoxemia. All right. So that's about this question. I hope it's clear.
Thanks for watching. Please give a thumbs up and subscribe for more.